and subsequently did his FRCR from Royal College of Radiologists, London. Subsequently, he worked as a research associate at USA at the Emory University, Atlanta for 2 years from 2005, and he did 2 fellowships, one in neuroradiology at the same Emory University, followed by a pediatric radiology fellowship in 2009 and 2010. He worked as a pediatric neuroradiologist and as an assistant professor of radiology. Subsequently, he was a pediatric neuroradiologist at the Cleveland Clinic, an assistant professor of radiology at the Case Western Reserve University, Cleveland. Got promoted as an associate professor at the Department of Medical Imaging at University of Arizona, and he's been a professor at the same university from 2019 onwards. He's a director at the American College of Radiology Society of Pediatric Radiology course at ACR Learning. He's also a member of the core examination committee of the ABR, the American Board of Radiology. He's also been a member of multiple committees of RSNA, ARRS, Society of Pediatric Radiology, American Society of Pediatric Neuroradiology, and ASNR. And he won multiple teaching and mentorship awards. So today he'll be talking about imaging before epilepsy surgery. We have Dr. Rammohan will be adding with his experience, and all of this, please share your thoughts in the chat box. He'll also be showing 10 cases. It could be an interactive session with the audience. So please type in your responses in the chat box as and when he pops up his cases. We hope to have a fruitful discussion and enriching educational experience today. Thank you one and all. Dr. Unni, are you there?
Yes. Can you hear me now?
Yeah, fine. Please go ahead, okay. Dr. Unni. You can share your screen and go ahead.
I did share my screen. Can you see the screen?
Yeah, now it's there.
Okay. First of all, I want to thank you, Dr. Ishwar Chandra, for his kind introduction. It's truly an honor to be a part of this educational initiative from KREST. I trained almost a decade and a half with the great Dr. Subbarao, and he continues to be a guiding influence in all our lives, even after all these years. And I'm happy to contribute my small part in this big endeavor. And I want to give kudos to Dr. Vijay Bhaskar, Dr. Ishwar Chandra, and Dr. Kavita for organizing such a great international event. I believe I'm the third speaker in this KREST International Speaker Series, or the live webinar. And I've had the great fortune of working not just with Dr. Subbarao, but a great bunch of teachers and educators at NIMS and great colleagues. In fact, two of the previous speakers were colleagues of mine, Dr. Siddharth and Dr. Venkat Subbiah. I just want to give you a brief anecdote before I start. So back when I was a senior resident at NIMS, I had the great pleasure of doing quizzes for the junior residents. And Dr. Subbarao used to have these nicknames for some of the residents. So I remember one day I had shown to a case to Dr. Siddharth, who was our first speaker, and Dr. Subbarao just kind of chided me and said, "Oh, you called the pundit." And Venkat Subbiah was obviously called the boy wonder. So I am following the footsteps of the pundit and then the boy wonder. So it's an unenviable task, but I will try not to disappoint you guys. I'll try to make it simpler, not too complicated, because developmental anomalies of the brain, which is mostly what epilepsies and epilepsy surgeries tend to focus on, can get a lot complex. And these are based on my experience working in a large pediatric surgery center, and try to go through some cases. Some of these cases may be a little challenging, especially if you're not doing dedicated neuroimaging or pediatric neuroimaging, or it may be very simple for you. So this is a cross-sectional imaging spectrum in pediatric neuroradiology and also in epilepsy surgery. So hope you enjoy these cases. I am, as mentioned very nicely by Dr. Chandra, a professor of radiology at the University of Arizona. So I'm right here in the southwestern desert of the United States, pretty close to Mexico. We have a fair number of patients that actually come over from Mexico, and we see some unique cases related to that. I'm surrounded by, as I said, it's a desert, but it's a different type of desert than what many of you have envisioned. This is called the saguaro cactus. So I'm surrounded by cacti in the central and southern part of the Arizona. Arizona is more famous for, of course, the Grand Canyon. It's a Grand Canyon state, but it also has very unique geological formations and beautiful places to visit, from the red rocks of Sedona to some places which were, they look pretty alien to you. So if you go to the northern part of Arizona or Utah, you might see something like a Martian environment. So if you are in this part of the country or anywhere in the United States, I know the pandemic restrictions don't allow any travel, but if you get to travel to the United States, I recommend that you please visit Arizona for its geological wonders. And if you are in the area, please contact me and come please visit. So what I'm trying to do here is, in the next hour or so, is to define the role of imaging in seizure and epilepsy. I'm going to give you some common indications and rationale for pediatric epilepsy surgery, review the role of imaging in preoperative assessment, understand the major types of epilepsy surgeries performed, and do some radiopathologic correlation in surgical causes of epilepsy. So before we go to epilepsy surgery, it's important to identify or define what these terms really mean. So there's also a confusion as to what seizure is, or seizure imaging versus non-seizure imaging. So I am talking about a process which is usually transient due to an abnormal, excessive, or synchronous neuronal activity in the brain. That's what a classic definition of seizure is. Whereas epilepsy is a disease characterized by recurrent, unprovoked seizures, often associated with other neurobiological, cognitive, psychological, and social consequences. So it's just not what you see on imaging or just the neurologic aspect of it. It's a spectrum that involves multiple different entities. So a lot of times when you are in the imaging area, you are imaging a new onset seizure. So is there really a role for neuroimaging in new onset seizures? Because most seizures are associated with conditions that need immediate medical attention. The main purpose of imaging is to assess that purpose. And it also depends on the seizure semiology. So semiology is an interesting term. It basically saying the study of the signs. So it's a classy term to use if you're a radiologist and say that, oh, please correlate with, we are often criticized for saying clinical characteristics or correlate clinically, but maybe you should sound a little more learned if you use something like correlate with seizure semiology. It's basically the symptoms of seizure, which is basically a way to identify where the seizure is coming from. So it could be directionality, laterality, or it could be the aura, motor, tonic-clonic, everything comes under the term seizure semiology. There's no real indication for imaging in febrile seizures. Also, there are some studies that show that there may be a prophylactic value in terms of long-term complications of febrile seizures, but not in the immediate stage. And there's always going to be a referral to a pediatric neurologist to assess these patients before getting any imaging done. Having said that, in real life situation, at least in my practice, a lot of these kids, even at the initial stage, get fully evaluated for seizure or epilepsy. But there are some areas where even when the patient has seizures or epilepsy syndrome defined or epilepsy disease defined, there are some areas where indications for immediate imaging. If there's a neonate or a young infant with new onset or unprovoked seizures, there's a concern for a traumatic event, especially in the heading of a accidental or non-accidental. And when you have signs of non-accidental injury, it's important to get immediate imaging. If they have a bleeding diathesis, if there are signs of increased intracranial pressure and presence of focal neurologic deficit. And if there are signs of infection, such as meningitis that needs immediate lumbar puncture. And lastly, if there is a recent brain surgery, you might need an immediate surgical condition. So first clinical pearl and first case, it's a little bit of a challenging case. The point I want to make is when you have epileptic encephalopathy, and if you have bilateral abnormalities that are symmetric in nature, this is one of the conditions in a neonate with hypotonia and continued seizures. I wanted you guys to just look at these images and see, given that history and the instruction as to this is going to be a metabolic condition, see in the chat if you want to come up with a diagnosis for this. While you're thinking about it, I want to give you some findings. There is lack of myelination. There's not a lot of T1 signal in the posterior limb of the internal capsule. There is abnormal cortices predominantly in the frontal regions bilaterally. This is somewhat of a polymicrogyria kind of a pattern. There is this cyst in the ventricle. I'm not seeing the chat window, but I hope some of you have gotten it correct. These cysts are called germinal-lytic cysts. So this is somebody with Zellweger's disease, or it's a peroxisomal deficiency. So even if you didn't get the diagnosis right, the key here is when you have symmetric abnormalities, as I said, metabolic conditions can cause seizures and epilepsy diseases. Symmetric abnormalities, think about bilateral symmetric abnormalities, always think about a metabolic condition. So once you have ruled out metabolic conditions, once you have ruled out any other medical or systemic conditions that are causing seizures and corrected agents, then you can come to the term of identifying surgical candidates. So for that, these surgical candidates come to the large category of medically intractable epilepsy. So medically intractable epilepsy is when you have two appropriately chosen, well-tolerated first-line anti-epileptic regimens fail because of their lack of efficacy, and where the minimum seizure-free period is 1 year or 3 times the pre-treatment inter-seizure interval, whichever is longer. So this is the International Association or League Against Epilepsy classification. But remember that surgical candidacy is to be determined on a case-by-case basis, using data from extensive multimodality assessment. And there's a renewed interest in the plasticity phenomenon, which is important to recognize because in the past, people used to wait before getting epilepsy surgeries, but there's more emphasis on plasticity. That means the earlier these brain surgeries are done in these children, the rest of the brain or other areas of the brain can take up the functions that are done by the areas that are resected. So early surgical intervention that maximizes efficacy, recovery, and cognitive potential. So what are the key considerations of doing the epilepsy surgery? Is there a structural lesion identified? So that's what you need an MRI for. And then if you see a structural lesion identified, that doesn't mean that comes out and the patient is lesion-free, because you have to make sure that that structural lesion is the epileptogenic zone. So remember, the epileptogenic zone comprises of actually two zones: the ictal zone, which is the structural abnormality, and the irritative zone, which is the irritated area surrounding the ictal area. So there is abnormal firing from one area of the cortex that it goes and irritates the rest of the cortex or surrounding area. So they both combine to form the epileptogenic zone. And it is usually done by EEG or functional imaging such as SPECT or PET. And then are these two areas concordant? Are the abnormality that you see on the MRI and the abnormality that you see on the functional imaging, do they overlap? Then you decide to do the surgery. And then once you decide to do the surgery, you look at the rest of the areas in the brain, its relationship to eloquent cortex. So MR landmarks, functional imaging, certain language or motor skills that are going to be affected. So you get a better idea of how to perform the surgery. And when the next question you go to ask is it going to be a focal resection or an extensive resection? Is it going to be a single or a multiple? Is it going to be unilateral or bilateral? So those decisions will depend on the structural and functional studies that you perform. So here is a gamut of structural and functional studies that you do. I mean, this is the first thing that any surgical or epilepsy candidate would undergo. This is an EEG. And then you have structural, that our bread and butter sequence is going to be MRI. There is PET-CT or PET or SPECT imaging, functional MRI. Once you have decided to resect the lesion, want to know where the key functions are present. There is also some other functional modalities that you can use. You have the subdural grid, which is basically we do a craniotomy and place some subdural electrodes on top of the brain surface. Sometimes you actually put deep electrodes to make sure this is an assessment of the structural abnormality and the functional abnormality are correlated or concordant. This is a magnetoencephalogram. One of the challenges with EEG is when you have an abnormal focus, let's say in the brain, and you're recording it on the top, the electrical signal has to go through the brain parenchyma and the calvarium to be recorded onto the EEG strip. This leads to some attenuation because it has to go through this tissue. But when you do something called magnetoencephalogram, or here the direct assessment, we call it electrocorticogram. Electrocortical functions are assessed by direct placement of the electrodes on top. The magnetic field is not hindered by the overlying tissue or the bone, so that you can directly visualize the area of the abnormality since the attenuation is much less on a magnetic field. You probably are all familiar with DTI or tractography, where we look at the effect of the surgery on underlying brain tracts. And sometimes you just place an invasive electrode to be very sure that you are looking at the structural abnormality, and that is the cause of the abnormal signal, and the patient would benefit from this surgery. I'm not going into depths of how to perform an MRI because I know that we are all radiologists. We want to see images, and I promise you that there's only a couple more of these word slides, and then we will go into a bunch of pictures. Please remember that there's always some confusion as to what kind of MRI is being done. A lot of times when you are imaging the patient for the first time, you don't really need a 3 Tesla MRI. But if the patient is being referred for an epilepsy surgery, and it is to be expected that the patient has established an epilepsy, and we are looking for subtle lesions in the brain, it's important to do an epilepsy protocol, and preferably on a 3 Tesla. There are many studies that shows that 3 Tesla is significantly more accurate in identifying the lesions when compared to a 1.5 Tesla. Our protocol, the workhorse sequences tend to be thin section, usually isotropic sagittal T1 and sagittal T2 flare through the entire brain. We have thin section axial T2 without skipping. And when you do a thin section coronal, it's important in children to have the whole brain, because in the adult population, the hippocampal area and the perpendicular nature to the orientation of the hippocampus is often emphasized. In pediatric age group, as I will come in a second, hippocampal sclerosis is not a major concern. So we want to include a thin section coronal to the whole brain. There are some additional sequences like SWI or DWI or DTI. We don't usually use gadolinium. It's not recommended for an epilepsy surgery. So without gadolinium, the perfusion is usually, if you're doing it, you can use an ASL, arterial spin leveling technique for perfusion imaging. We don't use routinely spectroscopy either. So this is the big picture, but the key is to have a very specific high resolution MRI protocol. And once you decide to do surgery, you want to know the functionality. One of the ways that you do is through functional imaging. You can do motor, language, rhyming, or word generation to see where the abnormalities on the left side, and you want to see if any of the key functions are going to be affected, so you can talk to the patient on a better basis. The nuclear medicine studies, we do either interictal PET or ictal SPECT. You identify the eloquent cortex, also to confirm the ictal focus. We want to identify pathophysiology of the partial and generalized seizures. Ictal hypermetabolism will not only be seen in the source of the lesion, but it will be seen in any cortex to which the seizure has spread. That's why it's important to know the ictal focus versus the irritative zone, which is where the epileptogenic zone comprises of both. So the goal of the surgery is to resect the epileptogenic zone. But if it is too large and if it is less well defined and the patient is having severe seizures, you may try to disconnect the avenues of seizure spread. So the seizure that is generating in one area of the brain is not being spread to another area of the brain. So largely, these are the major epilepsy surgeries that are done. There are some smaller ones. If you have a very well-defined lesion, you do a lesionectomy, you do a temporal lobectomy, hemispherectomy, corpus callosotomy, multiple subpial transections, radiosurgery, or placement of vagal nerve stimulators, which is not really a brain surgery, but it's a surgery associated with seizures. The recent but a major study actually comes from India, because even after all these years, there are now real evidence. So this NEJM article from 2017 from AIMS looked at 116 patients that were randomized into drug medical arm and the surgical arm. And there was a significant difference in seizure outcome in kids that underwent epilepsy surgeries. So there's evidence to show that this is really something that needs to happen, especially given the catastrophic nature of some of these epilepsy surgeries, and early because of the plasticity. All right, so no more word slides, I promise. So here's what we're going to do with we have a lesion in the right frontal lobe, and it's pretty straightforward. Lesionectomy. You resect the lesion and you're done. Then once you resect a lesion, it's important to go do a pathologic analysis to see what kind of lesion it is. The most common surgical pathologic entity after surgical resection, including children and adults, is mesial temporal sclerosis. But mesial temporal sclerosis by itself tend to be very rare in children. So the most common pathologic abnormality in children tend to be focal cortical dysplasia, otherwise called mild malformation of cortical development. There are some schools of thought that tuberous sclerosis and some extensive pathologies such as hemimegalencephaly are extensions of the malformations of cortical development. There's a large classification of focal cortical dysplasia. The type 1 are usually, or the type 2 are usually the hardest to find, and these, the type 1 and 2 tend to be the most common ones seen. But the type 3 can be associated with either hippocampal sclerosis when it's 3A, associated with a glioneuronal tumor when it's 3B, vascular malformation or other injuries. So these can all be associated with a focal cortical dysplasia. The most important one is actually the focal cortical dysplasia type 2B. I'll talk about that in a second. So again, remember what you are trying to identify in an epilepsy surgery is a focal cortical dysplasia, because half the patients on a surgical sample tend to be focal cortical dysplasia. Even with the best technique, we are only 50 to 60% able to identify these techniques. So there's a lot of patients with focal cortical dysplasia that we are not able to identify even with the best technique. So there's a limitation to what we are actually doing. So here's an example of a focal cortical dysplasia. I don't know if any residents are in here, but how I approach these studies is my most sensitive sequence tend to be the FLAIR imaging. What I usually see in the FLAIR imaging are the subcortical T2 or FLAIR hyperintense signal. So there are three classic imaging findings in focal cortical dysplasia. Number one is this subcortical FLAIR hyperintensity. Number two is the thickening of the overlying cortex. And three is a blurring of the gray-white interface. So these are the classic imaging features. I start looking at the FLAIR to see if there's a subcortical signal. That's why it's important to get an isotropic FLAIR in three separate sequences, three separate planes. And the blurring is very well defined either on T2 or the FLAIR sequence. So this is a focal cortical dysplasia. Please also remember that these lesions usually tend to be volume neutral. That means there is no loss or enlargement of the brain parenchyma because they're just dysplastic brain tissue. So this is focal cortical dysplasia. Here's another one. A very characteristic imaging finding that has been described is this under subcortical T2 signal that extends into the adjacent ventricle. I'll show you another example. And this abnormality, this abnormal finding has been related to a particular pathologic finding on histopathology. So these are called balloon cell dysplasia or focal cortical type 2B. In the past, it used to be called Taylor type. So there's a distinct radiological entity that is always associated with the distinct pathologic entity. So this is type 2B. That always gets a lot of attention. Here's another one. Having said that, I think if you just looked at the T2, you may point to this area of abnormality. There's the classic findings I described. The subcortical T2 or FLAIR hyperintensity, the blurring of the gray-white interface, and the thickening of the overlying cortex. So this is a patient with focal cortical dysplasia. I'm not saying that all of them will have this finding, but these are the classical findings. So it's easy. So we are in the lesionectomy stage. So you go, and resect the lesion, and usually it's a seizure-free, symptom-free outcome for the patient. So here's another patient. You see this subcortical flare hyperintensity, blurring of the gray-white interface, and also the thickening of the overlying cortex. But here is that line that extends from the subcortical region to the periventricular region. So this is what is called a translaminar sign. And here it's a very easy resection. The functional and the anatomic abnormalities correlate. Are they concordant? So they resect the area. So this is a focal cortical type dysplasia type 2B or a balloon cell dysplasia. And this is your classic transmantle sign. The mantle is from the periphery of the brain parenchyma to the periventricular region. So this is a transmantle sign. You can have multiple focal, some unfortunate kids have multiple areas of cortical dysplasia. Again, the classic imaging findings in the left frontal region. There's a little more subtle area in the right parietal region, the right frontal and right parietal, and they were both known to cause or both identified as the region for the epileptogenic foci. So they resected both the frontal and the parietal region. So here is that resection, immediate resection of both the cavities. So this is lesionectomy, but multiple lesionectomies. So here's it gets a little bit interesting. I know that I'm not going to test your ability to identify this case. This is pretty straightforward. I don't know, for the residents, if there are any, I'll just explain, I'll just describe the findings for you. You see this subependymal nodules that are calcified on the T2. You can probably say there are some subcortical or cortical signal abnormality that are scattered. On the MR, you see this cortical subcortical abnormality. And if you individually look at them, so this is a patient with tuberous sclerosis. So in the past, tuberous sclerosis, otherwise known as a combination of epilepsy, low intelligence, and adenoma sedation, used to be considered as a global disease of the brain parenchyma and used to be medically treated. But there is more and more evidence that these individual abnormalities look more like focal cortical dysplasia with a translaminar sign, with all those classic imaging features. If you look at all these quote unquote original cortical tubers. So there's a more, there are increasing evidence now to show that the individual, if you identify some of these, some of them tend to produce are the cause of seizure more than others. So if you have a seizure abnormality, and even if there's diffuse abnormality, there's a push to identify the abnormal lesion and then resect it. So that's why I said initially that for tuberous sclerosis is now considered by many to be an extension of the focal cortical dysplasia. So I showed you some classic imaging findings of focal cortical dysplasia. It's a little not so classic. You see the abnormality, if you look very carefully, it's over here in the left frontal lobe. See some thickening. Not a lot of flare signal abnormality. This happens, not infrequently. So I just want to give you a spectrum of classic abnormality to some of them where you are probably not going to see. So an abnormally thickened gyrus or an abnormal sulcation, a sulcus that is not supposed to be there, is a key to an underlying cortical dysplasia. So remember, the brain is symmetric. The symmetry is your friend. If you have an asymmetric sulcus in the brain, and in a patient with seizure, always look for a cortical dysplasia. All right, so the next big classification after cortical dysplasia are tumors. There are some specific tumors in the pediatric age group. They almost originate from the cerebral cortex. They're a mixture of glial and neural elements, benign biologic behavior with low mitotic activity. They're stable or slow growing, and they're associated with cortical dysplasia or dysplastic neural elements. So there's always a spectrum from cortical dysplasia to tumors because these are low growing tumors. All right, here's your next case. I'll give you a few seconds to answer. This is a young kid with seizures. Anybody wants to okay, so I'll start describing. So one major difference that you see from the cortical dysplasia to this one right off the bat is you see the inner scalloping of the skull, right? So as I said, the cortical dysplasias don't tend to be volume positive. So here you have the inner scalloping of the skull. So it has a mass effect. Number two, it has a cystic component. You see that T2 hyperintensity, and the flare, it is not seen, the fluid is suppressed. So it is very similar to CSF. So it's cystic consistency. Otherwise, you would say it is a cortical dysplasia because it has that T2 signal. And so this is a cystic lesion. This has cortical dysplasia. Can you hear me? I think the host has muted everyone.
We can hear you. Go ahead, please.
Vijayabhaskar, you need to unmute Unni.
Yeah, I unmuted. Okay. So the cystic lesion. So this is a patient with ganglioglioma, and is usually seen in the temporal lobe. So the classic description is that I showed you a non-classical case. The classic description is in the temporal lobe, a low-grade cystic lesion with calcifications and an enhancing nodule. It's not intensely enhancing, but there's also a solid component that enhances. So that was a patient with ganglioglioma, which is a very unique lesion with the seizure in this age group. All right, here's another patient. This is not a cortical dysplasia. This looks volume positive, slightly heterogeneous lesion in the right occipital region. It's subcortical to cortical in nature. The patient had some seizures. There's a little bit of edema surrounding it, and it's pushing on the ventricle. Again, so we have anyone else? I'm going to give it a try in the chat. I don't know if there are residents, but so this is the second category of lesions that we see in pediatric age group in this cortical-based tumor classification. This is a pleomorphic xanthoastrocytoma. Here's another one. Again, I showed you one that is not really classic, so it's easy to resect. So it's there's a resection. We're talking about epilepsy surgeries. More classically, it has a large cyst. Again, these lesions tend to be in the temporal lobe, a large cyst, really enhancing mural nodule. This is the most classic appearance of a pleomorphic xanthoastrocytoma. So the third category of lesions or brain tumors, this is very classic. Again, if somebody wants to go and fill in the chat, please go ahead. This is one of the most common and classic ones that has been described. What you see here is, you have the normal gyrus on the other side. On the left side, the gyrus is in the cystic enlargement of the gyrus. And if you do a cross section like this, you might see these small bubbly lucencies. And on the flare, they are suppressed, so they're more cystic. There's no post-contrast enhancement at all. And you see this abnormal signal that extends into the adjacent ventricle. So there's a higher incidence with an associated focal cortical dysplasia. And again, you see that inner scalloping of the inner table of the skull. So this is a chronically expanding tumoral lesion that is seen in the left frontal region. This is a classic example of this embryoplastic neuroepithelial tumor, or a DNET. And again, it's a focal resection of the lesion. And this is another lesion. Again, it is pushing on the skull, is chronically enlarging. You may call it, you might end up calling it a focal cortical dysplasia based on the T2, but on the post-contrast imaging, you can see some enhancement. So this is actually a tumor, because you don't expect any enhancement in a patient with a focal cortical dysplasia. So this is an oligodendroglioma. I just want to use a few seconds to talk about the 2016 WHO classification of tumors of the CNS. And there are a couple of new entrants on this classification that have been described in the last 10 years or so. This is some of the tumors that we have already described in neuronal and mixed glial neuronal tumors. And luckily, the ependymal and the inner brain tumors don't usually present with seizures. So these are the tumors that are most likely to be associated with seizures. So here's one of those new additions that have been described in the last 10, 15 years. This is a type of a glioma, or an astrocytoma. Usually presents very well-defined and homogeneous enhancement. WHO classification didn't really classify it as into a type 1 or a type 2 because it's still fed as an unclassified lesion. So anybody wants to go on the chat and say, what do you think about this one? All right, so this is one of the newer tumors. This is called a pylomyxoid astrocytoma. This is a myxoid stroma, which gives that uniform, well-defined enhancement and this T2 hyperintensity. And it's one of those new tumors. Another new tumor that has been described is the one that you see here. It's a little bit ill-defined. It's usually surrounding the vascular channels, and there's always an extension to the ventricle. And there's an association with an underlying cortical malformation or focal cortical dysplasia. This is what is called an angiocentric glioma. So these are the two pediatric specific new tumors that are associated with epilepsy that have been included in the 2016 classification. Again, it's a direct resection, it's a lesionectomy. There's an adult tumor that has been associated with the epilepsy that unfortunately we don't see much in children. This is another lesion. Some people call it a touch me not lesion. These are seen in the subcortical nature. It goes along the gyral pattern. There's this small flare hyperintensity. I think you probably have heard this term before. It's something called a multinodular vacuolating or neuronal tumor. But luckily, we don't see this lesion in children. The true nature of this lesion, because we see these abnormalities incidentally in a lot of children, so the correlation with the seizure is important before you decide to resect it. Sometimes non-tumor lesions, such as a cavernous malformation, such as here, can look like a lesion, but remember, when you have the classic imaging findings, especially in this patient had it in the lateral temporal lobe, cavernous malformation, and this is a lesionectomy for straightforward resection. It should be curative for this patient. The third category is scar or gliosis, especially in someone who had prior trauma, infection, or other pathologies of the brain parenchyma. This was somebody who had an insult to the left frontal lobe. You can see this asymmetric enlargement of this sulcal space. So there's a focal atrophy of this lobe with an underlying gliosis, which is the T2 hyperintensity within the subjacent white matter. And so straightforward resection. So gliosis and scar because of the gliotic tissue misfires and leads to seizures. Okay, here's a young kid. Again, this is a test case. If anybody wants to answer, this is somebody who's a year old or even less than a year old, presenting initially to the ED with these findings. Rasmussen's, okay. It's a good thought. But if you see it in an adult, so there is some, this is a diffusion sequence. There's some diffusion abnormality in the periinsular region. You have the frontal pole, the temporal pole, they're both affected predominantly in the temporal region. There is diffusion abnormality with some meningeal enhancement, right? So you are thinking of somewhat of an infectious cause. So if it is in the temporal lobe, even in adults or children, the herpes infection is one of the most common ones that are affecting that region. So this was a straightforward herpes in this age group. But please also remember that there are two different types of herpes in children. It could be either a neonatal herpes or adult herpes. They look a little bit different, but this is more of an adult type of herpes infection. The kid came back after a year. There's post-infectious atrophy and gliosis and encephalomalacia. Now this is a seizure focus. Now this is causing extensive epilepsy to a catastrophic degree, and it affects the whole, the right hemisphere is a little bit smaller than the left. And it's a straightforward resection. So sometimes the post-infectious pathology itself can be a cause for this seizure focus. All right, so we identified the lesionectomy, which was the first group. And the second group is actually temporal lobectomy. This is mostly the adult group, but there's a lot of lesions, as I described, that are in the temporal lobes, and again, malformations of cortical development, neoplasm, mesial temporal sclerosis, vascular anomalies, and again, primary MTS is rare in children. So there are two major types of, you can do two subtypes of temporal lobectomy, either the standard anterior temporal lobectomy where you resect the entire anterior temporal lobe, or you can do a selective amygdalo-hippocampectomy. So you resect the amygdala and the hippocampus. So here's what happens in an amygdalo-hippocampectomy. You resect only the amygdala and the hippocampus, where here you, in addition to the amygdala and the hippocampus, you resect the entire anterior temporal lobe. So anterior temporal lobectomy. This is a more complex procedure. Sometimes you also do other very specific temporal lobe surgery. So it's important to look at the history to know what exact type of temporal lobectomy was performed. So this is a classic imaging finding of a mesial temporal sclerosis. You see abnormal signal intensity within the right hippocampus. There's an enlargement of the ipsilateral lateral ventricle, the temporal horn. And we did a selective amygdalo-hippocampectomy. So there's a lot of areas of the right temporal lobe that are left behind. The goal is to preserve the remaining temporal lobe. But access to this area is challenging. There are some studies that show that going through the ventricles is a way, possibly through an endoscope, or as approaching it from an anterior or lateral approach and going here and just resecting the amygdala and the hippocampus. The approach can be either transfilvian, transcortical, subtemporal, or different variations of it. But here's a malformation of the cortical development of the right temporal lobe, and where did an anterior temporal lobectomy. So this is the entire lobe was resected, not just the amygdala and the hippocampus. Here's another one. We already saw one of these lesions, the cystic change, the enhancement. This is a Ganglioglioma, did an anterior temporal lobectomy of the entire left anterior temporal lobe. Here's another lesion. This is an ill-defined mass. This is an Oligodendroglioma affecting the right temporal lobe. And then we performed an anterior temporal lobectomy to resect it. It's basically a lesionectomy, but it's in the temporal lobe. But you do sometimes, a lot of times it's not just the lesion, but the entire temporal lobe is removed. Occasionally we have unusual lesions, so that can cause seizures. This is not usual. So this is actually an intraventricular lesion with some dark T2 signal and enhancement. This is an atypical meningioma in the right temporal lobe that was causing some mass effect and causing secondary seizures. Again, something like a cavernous malformation can occur anywhere. So this is a cav mal in the right temporal lobe causing seizures. Again, temporal lobectomy was the answer. But occasionally you have a non-resectable lesion or hard to resect lesion, such as a AVM. This is an arteriovenous malformation in the right temporal lobe. And here's a CTA that shows the right temporal arteriovenous malformation, which is probably, which could be treated depending upon the nidus and the access to it. But there are endovascular alternatives available. So that leads to my next set of slides. Is that what are the less invasive options for intractable temporal lobe epilepsy? There are radiofrequency, gamma ray, or a stereotactic laser ablation, which is currently performed in where I work. And it's mostly, again, a lot of these people are adults because isolated temporal lobe epilepsy or mesial temporal lobe seizures are in the children. So it's a laser ablation of the medial temporal lobe. This is an MR guided stereotactic laser ablation, otherwise called stereotactic thermal ablation, where you place the probe under MR guidance right where you wanted it. This usually, in our center, it's done by the neurosurgeons because it's very similar to some of the movement disorder surgeries that they do, especially Parkinson's lead placement and things like that. So this was 3 months after the initial surgery, and 3 years later, you can see the defect in the right temporal lobe. Okay, so now we've seen lesionectomy. Then we saw a bunch of cases on specific area in the brain, the temporal lobectomy. We're going to look at extended lesionectomy or lobectomy. All right, this is a little bit of a hard case. Again, this is going to be a test case. Anyone wants to go for it, please do. While you are looking at it, I'll tell you the salient features. There is absence of the corpus callosum. There is a abnormal orientation of the frontal horn of the lateral ventricle, the moose head, or a moose horn appearance, what do you call it? There are some cystic changes. You can see one cyst in the ventricle itself. There's a high riding third ventricle. In addition, you see some cortical heterotopias. So the cortex that's supposed to be peripheral is lining the ventricle. There's some heterotopia. Plus, if you look at the cortex itself, it's not normal. So here you have more normal appearing cortex, but here they're not normal. So there's some overlying polymicrogyria kind of pattern there. Infolding is a more pronounced. So what abnormality is associated with absence of corpus callosum, high riding third ventricle, intraventricular cyst, or intracranial cyst, cortical heterotopia, and polymicrogyria. This patient may have eye abnormalities like coloboma. So this is a patient with Aicardi syndrome. It's not important that you have to get the syndrome right. But it's important from our perspective is that this area is abnormal. This is what is causing the seizures. So it's a straightforward, large area resection. So you resect the entire right frontal lobe, or most of it. So this is a, you can see those cysts within the ventricles very well. Here's another patient. It's actually more simpler case. I would, yeah, again, I would urge that anybody wants to attempt this one. It's not that hard compared to the other one. So the abnormal area is on the left side, right? The left brain parenchyma, the left hemisphere is smaller compared to the right hemisphere. And you can see that there is this cystic appearing area within the left brain parenchyma. With an this is post-surgical, I'm sorry. With an enlargement of the ipsilateral ventricle. So this is not a mass, this is secondary to an insult. So there's some atrophy, encephalomalacia. So this is a cystic encephalomalacia. And this is vascular in nature. It's a territory, right? This is in the MCA territory. So this is an perinatal infarct that caused secondary changes in the left MCA territory. And that is actually leading to misfiring of the neurons and causing the seizure. So here's your post-surgical images that you see the resection. Here's another one. Anybody wants to try? So you have an abnormal area over here. You can see it here. If you look carefully, there's a little bit more of a subcortical T2 hypose intensity. So the myelination is a little bit more pronounced and there's some thickening. But more importantly, in the post-contrast images, there is this enhancement along a large area, right? So this is a vascular abnormality. This is a developmental vascular abnormality affecting the brain and often in the trigeminal distribution in the face. So it's an encephalo-trigeminal angiomatosis. And this area of increased T2 hypointensity of the white matter has been described as hypermyelination, quote unquote hypermyelination, because we don't really know why this happens. It is supposed to be due to the increased firing of the neurons. So these are classic imaging findings. And if you look a little more carefully at the ipsilateral lateral ventricle and at the choroid plexus, they tend to be a little bit more pronounced and enhancing. There can be an associated development of venous anomaly. So this is a Sturge-Weber syndrome. Again, resection of that area. This is another patient with Sturge-Weber syndrome with more classic appearances, originally described as the tram track pattern. And then you have that abnormally looking T2 hypointense signal in the white matter. Remember in the initial phases when the child is really young, you don't see the atrophy of the brain. So the brain might look normal except for this increased T2 signal. Here the atrophy tends to start and then there's a little bit of prominence of the ventricle. So in the later stages, there's atrophy, there's tram track calcification. So this is a Sturge-Weber syndrome with the resection of the entire area. This is not your classic cortical dysplasia. You can see that it has some mass effect. It's pushing the cortical. This is ill-defined. There's no, it affects the cortex and the subcortical white matter. It is pushing the corpus callosum a little bit. So there's a little bit of mass effect in here. There's some associated edema. So this is actually a lesion. This was actually described as an oligoastrocytoma. Although these terms are really going out of fashion, I want to just quickly mention to you that a lot of the current and future classification of tumors, not just in pediatric, but in the adult literature, is based on the molecular characteristics. So just briefly, if you want to call anything glioblastoma, it has to be IDH wild type. If you have an IDH mutation type, they have significantly better outcome. So if you're looking at the outcome, it is based upon the molecular characteristic of a lesion and not necessarily how it looks on imaging. So I was listening to an Ann Osborne lecture the other day. They haven't really come out with the 2021 classification for WHO grade 2. So one quick example that remained with me was in the past when you had a low-grade astrocytoma and that underwent dedifferentiation and became a high-grade tumor, a lot of times we used to call it glioblastoma. But when you look at the molecular characteristics, the IDH variant does not usually change. They tend to be IDH mutant, not IDH wild. So unless you have an IDH wild type, you can't call anything a glioblastoma. So a tumor like glioastrocytoma cannot exist anymore because they don't have the same molecular characteristics. So if you're, their point is, I would recommend that if you are somebody who does a lot of tumor imaging, you look up this article on radiology a couple of years ago. And if you, the point is, if your aim is to identify a lesion and predict the prognosis, the molecular characteristics are more important than the imaging or the cytopathological classification. So the WHO classification is still not entirely molecular. So it unfortunately is the way that we may be less describing lesions as they are than giving them a particular name as to glioblastoma or astrocytoma. All right, here's another lesion in the left occipital lobe. This is a polymicrogyria. I showed you a couple of cases earlier. It's also resected. Here's another case that can cause seizure as a patient with schizencephaly in the right parietal lobe. This is another patient who's again in that same spectrum we spoke earlier about infarct, because we saw one with the MCA tertiary infarct. Here you have another lesion involving the right hemisphere. There's volume loss. There's enlargement of the subdural fluid collection. So this was some kid who was accidentally, not accidentally, this was abuse. This is a patient who had remote abusive head trauma. And remember, when you shake a baby, it's not just the tearing of the subdural veins, but there's also loss of blood flow to a certain part of the brain parenchyma, and then they can have atrophic changes as a sequela. All right, so the last classification of drugs, I'm a little over the time, I'll try to finish within the next 10 minutes, is hemispherectomy. So there are actually two types of hemispherectomies, an atomic hemispherectomy or a functional hemispherectomy. In anatomic, as the name indicates, you remove the entire brain hemisphere, only the deep brain structures remain. Whereas in functional, you disconnect one part to the other because you don't want the lesion or the seizure focus to spread. When anatomic hemispherectomy is considered, the epileptogenic hemisphere is usually severely dysfunctional. You have hemiparesis, and the language is mediated by the contralateral hemisphere. So the extensive resection is justified. You resect the frontal, parietal, occipital, and temporal lobes, just leaving the basal ganglia, thalamus, and the brainstem. So you have extensive malformation of cortical development affecting the entire left hemisphere. As I said, you do an extensive anatomic hemispherectomy after assessing the functions that are essential for the patient to survive, such as motor skills or language, and make sure that they're on the other side. So this is a patient with anatomic hemispherectomy. Here's another patient. This is a more straightforward case. If anybody wants to put in the chat, I'll start describing it. So you have a large right cerebral hemisphere, enlargement of the ipsilateral ventricle, You have cortical heterotopia, and even the brain parenchyma or the cortical sulcus appears really thickened compared to the other side. So you have multiple abnormalities. Usually when the brain is enlarged, you expect the hemisphere ventricle to be
इससे
smaller.
कल मुझे डाल भी देना ना, मैं एक बॉटल में लगाऊंगी ये, मतलब कल अगर तू नहीं आता तो कोई बात नहीं, जब
Can you please mute yourself,
बॉटल में
all the
लगाऊंगा, ये
delegates?
अच्छी है, ये काट के दे देना मुझे.
Dr. Madhvi, could you please mute yourself?
Sorry.
Okay, so this is a classic case of a hemimegalencephaly. So you do an anatomic hemispherectomy, you resect the entire right brain hemisphere with the deep brain structures remain. Over a period of time, it becomes more well-formed. The left hemisphere takes over a lot of the function. So hemimegalencephaly, again, the classic features. This is another patient who had extensive right brain infarct, perinatal or antenatal, with associated atrophic changes and encephalomalacia and gliosis. We did a anatomic hemispherectomy to remove the entire right hemisphere because of the nature of the disease and the extent of the seizures. In functional hemispherectomy, we don't remove the entire brain, you remove a window of cortex to make the appropriate white matter resection. So you also resect the corpus callosum, you resect the corona radiata and the capsule, you remove the fornix, the anterior commissure, and sometimes the brain parenchyma. That is the cause, but you don't remove, you remove certain areas. So it's not just to remove the area, but also to resect the connections from one brain parenchyma to the other. So here is a patient. For lack of time, I'll just go describe the abnormality to you. There's the entire right hemisphere is actually smaller compared to the previous case where the entire right hemisphere was big. And you see that the brain parenchyma is atrophic on the right side. The ventricles are a little bit bigger. The right ventricle is a little bit bigger. There is enlargement of the cortical sulci on the right side. There is T2 hyperintensity in the subcortical and in the periventricular region. So this is a patient with Rasmussen's encephalitis. And you do a functional hemispherectomy. You resect the abnormal area, but this affects the entire brain. So either you do an anatomic hemispherectomy, where you add certain functions to be maintained. You don't resect the entire, here we haven't resected the entire posterior temporal or the occipital lobes or some part of the frontal lobe, but you do this disconnection surgeries. So here's another patient. The abnormality was on the left side, as another patient with Rasmussen's encephalitis. And here you did another patient with the functional hemispherectomy. Here's a third patient. Again, we have seen a bunch of these studies already. This is a perinatal or antenatal infarct with extensive damage. So sometimes the decision to make anatomic or functional hemispherectomy is not based on the lesion, but on the functional nature of what the surgery is going to entail. All right, a couple more smaller surgeries. One is a corpus callosotomy. If you know exactly where the lesion is and they are causing intractable seizures, but the lesion focus is not resectable, and or when you don't know where the focus is, but you can tell where it's moving from one side to the other side, or when patients have multiple epileptogenic focus. This is also sometimes performed for drop attacks. So here's a patient who had a corpus callosotomy. So you get through here and resect the corpus callosum so it doesn't go from one end to the other. In some patients where the epileptogenic focus is in the dominant or eloquent cortex, a disconnection surgery that is done locally, which is called a sub-PL transection. You make a transection under the PIA so that the misfiring neurons don't get to transmit the abnormal signal from that area to the other area. All right, I think one more. So lastly, we have a unique seizure and a special surgery, right? So here's the last case. Anyone wants to go? It's a pretty straightforward case. You know, for residents, whenever they show a sagittal image, always look at the pituitary area. That's probably the abnormality is going to be, or in the corpus callosum. So I'm showing you a sagittal area. This is the infundibulum, this is the mammillary glories. So between the infundibulum and the mammillary body in the area of the hypothalamus, there is a lesion that is iso-intense to the brain, the gray matter on all sequences. It does not enhance, it's not calcified. So this is called a hypothalamic hamartoma, or the hamartoma of the tuber cinereum. Remember, these are classically described with the gelastic seizures or the laughing seizures. And these are direct resection. So this also comes under the seizure resection surgery classification. So this is my last case. And I'm just going to go review what we looked at so far. What we have, so I would classify these lesions as having a surgical objective, and what's the technique, and what are the candidates, and what are the lesions that we are resecting. So if you are local focal resection, we are trying to remove the epileptogenic focus, it can be a lesionectomy. When a discrete resectable lesion is identified in the, usually in the non-eloquent cortex, and we said that vast majority of them are going to be focal cortical dysplasia, followed by vascular, followed by neoplasm. We looked at a bunch of specific cortical-based neoplastic processes in the pediatric age group, or vascular abnormality, or focal encephalomalacia. And then the next category was temporal lobectomy. We looked at two types of temporal lobectomy, the specific or extensive anterior temporal lobectomy, and for lesions isolated to the temporal lobe. It could be any of the above conditions, such as a focal cortical dysplasia, neoplasm, vascular abnormality, or encephalomalacia, and it can also be primary mesial temporal sclerosis. And we looked at the anatomic hemispherectomy, which is resecting the entire one lobe. So that's the resection area. Then you come to the disconnection surgeries, where you want to interrupt cortical connections to limit seizure spread from one area to the other. There's a functional hemispherectomy. A lot of times functional and anatomic hemispherectomies overlap. When you have extensive or multifocal unilateral epileptogenic focus, again, bilateral is very hard to treat, and a lot of times bilateral abnormalities are metabolic in nature. So we saw cases of Sturge-Weber, Rasmussen, semimegalencephaly, corpus callosotomy, where you want to disconnect just part of the corpus callosum because you have extensive or multifocal, and you want to limit the spread of the epileptogenic signal from one hemisphere to the other, and also when the lesion is in the dominant or eloquent cortex. And lastly, a very rare surgery of multiple subpial transections in the eloquent cortex, where you want to just resect the underlying subpial areas. And we also saw one case of a specific condition, which is the hypothalamic hamartoma with gelastic seizures. This is a straightforward lesion resection in the suprasellar region. All right, thank you.
Oh, thank you, Dr. Unni, for such a wonderful presentation, taking us to the common lesions, to the very uncommon for us. We're very happy that you're working in a very niche area and a wonderful part of US. I think the geographic formations, what you showed, were equally as attractive as the cases you have showed. Excellent. We have local experience from Nizams and Dr. Ram Mohan, who has done a lot of work at surgical teams, neurosurgical teams. Any comments from Dr. Ram Mohan?
Yeah, excellent talk, Uday. And you touched the epilepsy zone of a lot of epilepsy radiologists. You went into the ictal zone of a lot of epileptologists. Actually, this is a talk which you should, the core team of the ecosystem also should join. The neurosurgeons and the epilepsy ecosystem, they would enjoy to the deep core. Some of the cases you showed, I think the case of the day would be pielomyxide astrocytoma. And of course, the macrogyrus is my favorite one. Many times I was clean bold macrogyrus variety of DNET. So Thank you very much, Uday. And I know you are the roommate of my very good friend and ex-student, Dr. Krishnamon at MRI.
Yeah.
Krishnamon keeps talking about you. And I thank Vijay Bhaskar and Ishwar to get such a great speaker to this forum. And God bless you and all the best. Yeah. Thank you.
Thanks for the active participation in the chat box, Dr. Sriram and Dr. Ramohan and others. Any other questions? There was a question in the chat box about febrile seizures. Could somebody who has raised that please elaborate on that?
They are not there. I think they have left now.
Yeah, that's fine. Any other Dr. Madhusudan Rao or anyone else? Kavita, somebody could chip in.
Unni, can you exit your share screen, please? Can you close your PowerPoint, please, Unni?
No, you need to, Vijay, you need to give a different links for delegates and faculty.
Yes, sir.
Because videos, video issues are there.
Yes, sir.
And they don't know their video is open. Right?
Yes, true.
Yes.
There's a question in the chat box. What is the treatment for secondary mesial temporal sclerosis? Dr. Unni?
So that's in children, when you have mesial temporal sclerosis, they are by nature secondary. So there's usually an associated cortical malformation or some other prior trauma. And you could argue that, we see mesial temporal sclerosis in the adults, they're all, because they're not seen in children, because they're not primarily a malformation. It's basically a secondary to changes. So the febrile seizures is also interesting because there's a lot of evidence to show that there's some patients who have had multiple febrile seizures can have secondary mesial temporal sclerosis. So I don't know whether some of these young kids or young people in their 20s and 30s who come with mesial temporal sclerosis, is it because they had febrile seizures in the past? And this is also secondary. So the treatment is always going to be surgical. I mean, if it's primary or secondary mesial temporal sclerosis. So there's going to be more. It's an area where we don't really know what the real nature of the febrile seizures and these incidents with the mesial temporal sclerosis.
Dr. Sandeep or Dr. Sriram, anything you want to add or any other comments?
Excellent presentation. Thank you very much.
There's a question.
Another one. Yeah, I can read. I saw a question with focal cortical dysplasia from angiocentric glioma. First of all, it's a game of statistics, like in everything in radiology. So focal cortical dysplasia tends to be way more common than angiocentric glioma. And angiocentric glioma is extremely rare. So it's a glioma versus focal cortical dysplasia, right? If it is a cortical-based tumor, even angiocentric glioma, there's incidence of 30 to 40% of underlying cortical dysplasia. So it's in a spectrum from cortical dysplasia to a cortical-based tumor. So they all need to come out if they are the reason for the surgery. And the presence of one or the other sometimes is actually identified on surgery itself. So enhancement really helps. If you think, I said initially that if you are thinking of a surgical candidate, you don't really give contrast, but occasionally when you're not sure, you could give contrast to see if how's the enhancement.
One question from my side, Dr. Unni. Those hemispherectomy surgeries, they look so, devastating, imaging-wise or otherwise. How do they perform in the later years? What is the functional status of those kids? How do they do? So,
a couple of things. One, you have to understand these are catastrophic seizures. They cannot stop seizing. So even after 3, 4, 10 drugs, I don't know if you have seen images of these seizing babies or kids, they are catastrophic events. So this is a last stage, sometimes they're palliative. So that's why the whole idea of plasticity. So we really look for very key survival motor, or what's the defect versus the stopping the seizure. So that's it's a catastrophic event and catastrophic surgery. That's why the emphasis is on doing these surgeries as early as possible, because of the utilizing the plasticity of the brain. The certain areas of the brain can take up the function at a much earlier stage compared to certain than later. So there are other areas of the brain. I think you all have seen, I can show you images of babies with really bad brain injuries, but they look not that bad compared to an adult, because they have the ability of the other areas to take up, say, a lot of these functions. So the key is to identify them at an early stage and do the surgery at an early stage. For two reasons. One, not to spread the abnormal, not to affect the normal area from constant misfiring, and also so that the other areas can take up those functions early.
Yeah, one last question in the chat box, Unni.
Yeah.
Which is more diagnostic of Rasmussen's encephalitis? Is it a characteristic EEG or imaging pattern of hemiatrophy? How to accurately arrive at a combined clinical radiological diagnosis of Rasmussen's?
It depends on where you work. If you are at a frontline imager, it may be harder because initially the findings may be mostly seen on EEG, and you might see a subtle initial finding is a subtle T2 or flare hyperintensity in the perinsular region that may not be diagnostic of Rasmussen. The images that you see on textbooks, on lectures, they're all very advanced form. So at that stage, the patient has really bad seizures, extensive abnormality. So sometimes as an imager, you could, if it is a couple of seizures, you have seen it, you can point to it, and they can do more investigations on the EEG to identify it. But at a later stage, when you have extensive injury, it is like, if you resect Rasmussen, it is like an infectious encephalitis. There is increased inflammatory products and microglia and all the other stuff. So there are at least 2 points where you can actually identify this disease. One, at an earlier stage, you could give some pointers to the epileptologist, and later on when it has classic imaging findings.
That sums up the whole presentation. Dr. Udayasankar for the concluding remarks.
Thank you, Unni. Thank you very much for a wonderful presentation. It was really great, and so methodical. Approach was something like any exam for all the residents, also someone going for exam, and the fantastic approach what you have mentioned there, given there. This presentation we are going to upload to YouTube so that everyone else can, who have not accessed this particular presentation, can go through and get enriched with the kind of knowledge you have shared with us. Thank you very much. Next will be after 2 weeks, it will be Dr. Sanjeev Prasad, who will be taking us to the presentation on venous compression syndromes. And I request all to get ready, because Sanjeev Prasad is one of the leading interventional radiologists abroad, and he can really take us to very great level regarding the venous compression syndromes. We'll come back to you with the program very soon. Thank you very much, and thank you, Unni, once again. Thanks all for participation.
Thank you, everyone.
Thank you. Bye-bye.